Hello, Dr. Joey. My name is Zaina Bolao, and today I'm going to be presenting on predicting stroke risk using logistic regression. And I am using SAS 9.4 for this project. I am a applied business analytics major with a data intelligence concentration, currently pursuing my master's in the Richards College of Business. Let me introduce you to clinical stroke um, generally. Clinical stroke is a sudden loss of brain function like speech, movement, or balance, and typically the symptom will last for more than a day, and it's caused by a problem with like the blood flow to the brain generally. Recently in the US, there's like about 795,000 strokes annually, and 145,000 of those leading to death. Increasingly, I also started to affect the younger population, which is causing a bigger concern for the country. The model aims to contribute to the improvement of prevention strategies by identifying key predictors of stroke using logistic regression. So the problems that we have is the problem of early identification of individuals at high risk. Despite advancements in the medical field, there's been a challenge when it comes to this because stroke has very different factors that affect it. There's no just one factor to stroke, which means that it is kind of unpredictable, right? So we want to address this gap by developing a logistic regression model to be able to identify these key predictors using publicly available data. Um, by quantifying the relationship between clinical risk and behavioral risk generally, we want to be able to seek support to support early intervention strategies and enhance decision making in stroke prevention generally. This project objectives are to predict the likelihood of a patient having a stroke based on their demographic or clinical variables. The demographic variables might be their age, their gender, and so on, while clinical variables will be some of the things that they do and then some other behavioral factors as well. To create statistical visualization as well to sort of explore the differences between predictors in between stroke and non-stroke groups. So we're going to be showing some um, visuals for you to see what kind of how the factors play out in different stroke groups, as you can see. So highlights also the significance of modifiable stroke risk factors, especially among populations that are under 65 years old, based on the patterns in this data. And I would also like to generate evidence-based recommendation for this project. So some of the literatures that I was looking at, Kelly Ayers in 2010 has also said, like, as populations grow and age, stroke-related complications and their effects on the quality of life remain pressing public challenges, right? And then the American Health Association or Arts Association also stresses the need for our primary intervention. There's also an increasing prevalence of stroke among younger adults, which adds another layer of concern, which means that a lot of younger people are now at risk of stroke, which is quite scary and will probably increase the number of deaths that the country is seeing via like stroke cases. WHO, I think, also mentioned that stroke is like the third cause of death in the world right now. And Stanford Healthcare also said that early detection of stroke risk by predictive model can enable early intervention and prevention, reducing the severity of stroke events. And like a lot of these literatures are sort of telling us and showing us that stroke has become an increasingly important conversation. We need to look for ways to predict stroke factors or what causes stroke generally so that we can have actionable preventions towards them. And some of these prevention modeling has become so critical that we have to actually do them. And several studies have also demonstrated how advanced analytics can support early detection and risk mitigation. So my data set was gotten from kego.com. It's a publicly available health data set. And we had about 5,110 variables in that data set. So these are the variables as listed: age, hypertension, heart disease, whether being married or not, smoking status, and stroke. People that have stroke or not are also like shown in there. Our target indicator here, like our outcome of interest, is stroke being 1 for people that have stroke and 0 for people that do not have stroke. So my methodology here is to clean and assess my data, sort of do my logistic regression, and then removed all of the unknown variables. We had some unknown values from smoking status, and also some non-applicables from BMI. And after I removed all of this, I had my data said my observations was it moved from 5,110 to 4,909. And I also encoded some categorical variables using class in SAS. And I also created some new variables. I created those new variables to sort of check whether some relationships or they work together or they work individually, basically. But I'm going to talk about that later. So I created all three and I created H squared. So this is what our descriptive data looks like, or descriptive statistics. This is what they currently look like. We have a very like fair number of females to male. We have about almost 3,000 females. We have about 2,100 males. We have some people that are married. Most of the observation or most of the respondents were married, with about 3,353 of them. Same thing, hypertension or hypertensive patients were way higher than, no, hypertensive patients were lower than non-hypertensive patients. And then we see some of this across board as well. So this is one of the visualizations. Here you're looking at the key predictor, one of our key predictor, age. So for age, generally, we saw that age, as you grow older, age adds the odds of plus 7.3% per year. And this is very statistically significant, which means that as you grow older, of course, you are at way higher risk of getting a stroke compared to people that are younger compared to you. And then hypertension adds about 63%. That's a whole lot, I know, but like, yeah, that's what the finding says. Average glucose level also adds, like, per unit of your average glucose level, you have a higher risk of plus 0.5%. And all of this are very significant at very low levels, so which is very good. It means that they are statistically significant. Also contributing positively, where we had smoking status, we had heart disease, but they were not very significant to this particular regression. BMI was not statistically significant at all. H squared as well was not a linear, like it was like a non-linear model. It just improved our model fit actually. So once you go past a certain age, it didn't matter anymore. So there was that too. So now I'm comparing age in non-stroke patients compared to age in stroke patients. As you can see in this box plot here, the midpoint here for non-stroke patients is much lower compared to that of stroke patients, which means that most of the stroke patients were like significantly older than non-stroke patients. I don't know if that's a good thing or not, but this is some of the things that we found in this case. And then I tried H squared. H squared is just me squaring age raised to power 2, just sort of detect if age has a linear relationship with stroke. So if you go past a certain age, do you keep being at risk of stroke, or when you go past a certain age, your risk of stroke becomes lower? And interestingly, I found out that when you go past the age of like 80, there's lower risk for you to have stroke compared to somebody who is at that age. So I guess we all have to live past 80. Once you don't have a stroke at 80, most likely you will not have a stroke again. But yeah, the median age for stroke cases is just much higher. That's the finding that we got from this visualization. Really. And this is a plot for hypertension. Hypertension, interestingly, almost all stroke patients were found to be hypertensive. Like, it's a full box, like it's almost all of them. You can see that here we have the non-stroke patients, and most of them were not hypertensive. We had some outliers here, but it wasn't very significant for us to like focus so much on them. Same thing for people's glucose level. So glucose level is another key predictor that the results detected. And as you can see here, the people that had stroke they had higher average glucose level compared to the people that do not have stroke. So with all of that, my findings are age, hypertension, and average glucose level were the strongest predictors of stroke in this population that we sampled. And generally, for each additional year of age that you add, the chance of you having a stroke increases by approximately 7.6%. Holding, if we hold all of the other factors constant, say like your smoking status or other behavioral risk that might increase those chances, if everything else was constant, age is going to be approximately about 7.6% for every additional year. Again, individuals with high blood pressure are about 62% more likely to suffer a stroke than those without high blood pressure. So everybody that is like sort of hypertensive, they need to pay more attention to like what they eat, what they do, because they are at very high risk of stroke. And for every unit increase in average blood sugar level, the odds of stroke go up by around 0.5%. So there's also that. And then the variables that I was talking about earlier that I tried. So I did a combination measure of high blood pressure, that's being hypertensive, heart disease, and being overweight. And surprisingly, all three of them did not show a strong link to stroke risk. So it's more or less like me adding together hypertension plus heart disease plus being overweight, and I named it all three. And these all three variable did not show a strong link at all to stroke risk. It was just like normal. It was not very, very significant. It was in the negative, but it was not significant. And also being male or female had no significant effect on the likelihood of having stroke as well. And so all of the other factors that, or all of the other variables that we looked at, they were not significant to this particular sample. So these are what I found out. So some of my recommendations based off of these findings are to prioritize early screening for hypertension, particularly in middle-aged and high-risk individuals. And I'm focusing on hypertension first because it had the highest percentage risk. It's about 62% risk for people that have hypertension to have stroke compared to people that do not have hypertension. So if we prioritize early screening for people, middle-aged individuals, so people in their 40s, people in their late 30s, we start to prioritize like measuring their blood pressure and making sure that this is a routine check for them or there's a routine check around that. I feel like we'll be able to sort of curb stroke or prevent stroke for them generally. Same number two is going to be to keep promoting glucose control programs for early diabetics detection and putting people on strict glucose regulation. So making sure that we watch our sugar level, watch what we eat, watch what we do, and then also making sure that we sort of like try to detect whether somebody is diabetic, especially people that probably have it in their family. Number three recommendation is going to be community health outreach. I feel like they should emphasize lifestyle-related risk factors such as poor diet, inactivity, and smoking, particularly for younger populations that are now increasingly showing emerging risk. So we want to watch our lifestyle and behavioral things because in my research, smoking status was like the one of the other predictors that contributed positively. It wasn't very significant, but it was smoking had a higher chance of individuals that were smoking rather had a higher chance of having stroke compared to individuals that were not smoking or that stopped smoking. So there was that. So my number four recommendation is going to be to integrate stroke risk calculators into clinical settings to help identify high-risk patients during routine checkups. Generally, this can be based on my logistic model, and we're going to have that just to help people just look up the percentage of risk that they could have and help them mitigate their lifestyle based off of that. So conclusion is that We have highlighted age, hypertension, and high glucose level as the most significant predictors of stroke risk in our population. So stroke likelihood increases with age, although it was not constant based off of the age square that we look at. So we see that risk for stroke may accelerate at different stages in life or certain ages. And these certain ages will be between like 65 to 80. And when you go beyond 80, there's a likelihood that the risk also reduces. Hypertension was a um, major concern because it substantially raised the odds of stroke. It was one of the highest as we were looking at those box plots that I showed earlier. While even moderate increases in like glucose level also contributes meaningfully to risk, which was like the 0.5 increase per unit of glucose level that I showed earlier. So BMI and other combined effects, we saw that it didn't really have a significant or statistical significance, which is very surprising because my hypothesis going into this project was that BMI was going to be part of these key predictors or it was going to be very significant amongst these key predictors. And then just a measure of BMI, hypertension, glucose level, and maybe smoking status were also going to be um, increased. But now we've learned something that some of those things they didn't necessarily have a significant effect on whether an individual have or has stroke or not. So some of the next steps that I'm looking at is to be able to use internal hospital data sets to sort of validate my findings with real world clinical data. So create this model on a more sophisticated level with actual clinical data and be able to sort of work with that clinic. And then also creating a mobile app with this clinic for patient level stroke prediction and recommendations generally, where patients can log into the app, speak to a doctor, they tell them to sort of fill out their lifestyle stuff and then they see it and the doctor sees it as well. I feel like that would be a very interesting next step just to execute. Um, but yeah, those are my next steps. So these are some of the references. These are some of the papers that I looked at, all of those literature reviews that I spoke about the other time, but these are all of them. Thank you very much for coming to this presentation. And this is the end. Thank you.